The reason we are doing this is because every day folks are dealing with new pain that doesn't go away.
Pain's a difficult thing to understand, so let people know what kind of options they have.
All right, Dr. Powers. Well, this is our initial broadcast, our initial podcast, I should say. And I'm real excited about it. It's something I've been wanting to do for a long time. I want to thank you for making it happen. Once you joined the group, and I told you I wanted to do it, you made it happen, and here we are. I'm Dr. Scott Glaser. This is Dr. Sean Powers. We're with the pain specialists of Greater Chicago. Our office is in Burr Ridge, and I guess the reason we are doing this is because every day folks are dealing with new pain that doesn't go away. And when that happens, they got a lot of questions. And every day we're giving people these explanations and helping them understand where their pain's coming from and what can be done safely to treat it. And we thought, you know what? Let's get this out there to the general public so that people don't have to wait to come in to ask us these questions. Let's make it part of the knowledge base of all patients. And so that's what we're going to do, right?
Yeah, it can help people, realize what options they have for pain, so that they don't think they're in kind of a hopeless situation. I think a lot of people, may feel that way. They may see some other doctors. Pain's a difficult thing to understand, and I think it's difficult for even other physicians to understand. I think it's a good amount of people that maybe have brought up complaints that maybe are a little bit unexplained by their general practitioner or whatever other physician they're seeing. And this is to be educational. It's to be engaging. It's to let people know what kind of options they have. Maybe get a few people in to see a pain management specialist a little bit sooner. Help make sure that they're functioning and they're happy with their life.
Well, and well put. Pain is not understood. This was not our field. Was not a field when I was in my fellowship. It was just beginning to be a field. There was kidney doctors and liver doctors and neurosurgeons, but there was no doctors who specialize in pain.
It's kind of an odd field, right? Because it treats a symptom versus every other field you think of: cardiology, the heart, or hepatologist, the liver.
Yes, it is a little bit that way, but we've learned so much now that we do know where it comes from. Yeah. We do know where it travels, how it gets to your brain, and now we can do. We don't do just pain management. Mm-hmm. Now the field is interventional pain management. Yeah. When we see a patient with pain that doesn't go away, the best thing is to find the source of that pain and treat it. That's just. With minimally invasive treatment, that's just the best thing that can be done as far as risk and benefits and possibility of benefit.
Interventional pain's kind of filled this gap between, it used to be, if you had pain, you either got put on medications or you had some very invasive surgery.
Right. Physical
and there was
therapy,
nothing,
medications, or surgery. That's what I was
really
trying
nothing
to
in
say.
between. Yeah.
Exactly.
So
and
kind of filled this gap.
Totally filled that gap. And it's a really easy way to think about our field is it's very similar to cardiology and cardiac surgery. Mm-hmm. I mean, when a person develops chest symptoms and then they see an objective blockage, there used to be surgery or medications and just hope you didn't have a heart attack and lifestyle adjustment. But now interventional cardiology, which started before our field, is treating these problems minimally invasively using fluoroscopy, which is what we use, live x-ray, where they're actually doing things that have much less risk to relieve the blockage, to improve the patient's symptoms. That's exactly what we do. We're like cardiologists of the spine.
Yeah.
And I'd like to transition just a little bit. I want to know, for you, what got you into this field? Because I know what got me into the field, but I want to hear a little bit about you, your background, and why you're in my office today.
Yeah. So looking back on how I got started in medicine, I grew up in a family that didn't have any doctors in it. Coming out of high school, I thought, I'm kind of interested in medicine. I had started as a ski patroller at this small hill in Wisconsin, and I did that in high school just to get a free lift ticket because I loved skiing so much.
Which hill?
Wilmot Mountain in
Classic.
Wisconsin. Yeah, so I saw the ski patrollers there. I thought that was a pretty cool thing. They were volunteers. I knew they got a free lift ticket, so I thought, well, you know what? Let's do this. What I found in there is that I really loved the skiing, but I really found an appreciation for being able to help people that were in need. So that tipped me off as I was getting into college. I thought, well, maybe I'll look into this medicine thing. And at the time, it seemed like that was such a far-reaching goal because I thought, wow, man, becoming a doctor, I know any doctors. But I applied myself. I did well in my exams. I was able to get into a medical school. I thought, awesome, this is great. I knew nothing about medicine still at that point. So as I'm going through my medical training, you got to figure out what type of doctor you want to be. You can't just, most of the time, you can't just come out and be, just a general practitioner. You can do that. A lot of people will specialize as well. So I was trying to figure out what was I interested in.
Yeah.
So I'm going into my third year of medical school. That's kind of the time where you really got to make that decision. And I was finding in a lot of my rotations, I loved medicine, really loved learning about medicine, understanding how diseases worked. And I was so excited to talk to patients about how they can improve certain things.
Yeah.
But, I found that, medical problems can be pretty difficult to understand for people. And it's just a lot of things you can't really see. I mean, high blood pressure is difficult for a person to appreciate.
In that case.
Yeah, or feel. It's difficult for someone to feel that. It's difficult for someone to really appreciate how important that might be. So I got a little bit disheartened by that. I felt like I really cared a lot, and I wasn't really finding what I wanted to get out of medicine. So I got a little bit disheartened. I ended up very randomly doing this selective in pain management. Had no idea what that was. Never heard of the field before. I knew it was something you could do if you were an anesthesiologist. That was about as much as I knew out of it. So I go into this, and I found this group of patients that really cared about their treatment.
Very salient to them.
Yeah, I mean, this was priority number one
Right.
on their list. Was I'm in pain. I'm not functioning well. I'm not living my life. I'm not enjoying my relationships. I'm having trouble. I need help.
Mm-hmm.
And so I found these group of people that really needed help, and I felt like I could make a difference in their life, and in a way that really maximizes their quality of life. So that was the moment where I realized, yeah, you know what, I think I want to go into pain management. That was my moment. What about yours, Dr. Glaser?
Oh, I love that story. I also did not come from a family of physicians, and my best friend and I in undergrad were like, we didn't know what we wanted to do. We just said, let's do the hardest thing. And in those days, it was being a doctor. Now it's probably like, some sort of
AI or
AI. Yeah, it's changed. It's probably not the hardest thing anymore.
Yeah.
And
It's still pretty difficult.
yeah, it was. But so it was kind of a little bit of a competition, and then we had another buddy who wanted to go to be a doctor as well. They found a calling right away early in medical school. They both became urologists, whereas I didn't really find a calling at first. And I went into anesthesiology because it's pretty amazing what an anesthesiologist does as far as suspended animation of the human being to get them through a surgery. It's a lot of hands-on, which I wanted to do. And as I was doing anesthesia, though, as I was finishing up anesthesia in the last year, I had an experience that kind of changed me forever. And that was, I think I've told you this story, but the second to last year, we would be giving anesthesia for thoracotomy cases. These are patients who are having chest surgery, typically to take a lobe out because of a cancer. And those are that and upper abdominal surgeries are the two most painful surgeries for patients to recover from. And these patients, who are often smokers, often older, it was tough because after we're done, They have less lung to breathe with. Plus, we had to give them all kinds of morphine because they're in such severe pain that we couldn't get them off the breathing machine because the morphine depressed their respiration. They were able to get less oxygen, and it was a real balancing act. And some patients would get pneumonias because they had to be on the breathing machine for so long, the ventilator. Some would get tracheostomies, and it was just a mess. And it was just like it's almost better to deal with the cancer. But in my last year, we started this program for putting in thoracic epidurals pre-op to infuse medication near the thoracic spinal cord where these pain symptoms, where the pain was coming in from the thoracotomy incision. And we were doing pain rounds, we call it. We'd come in the next day after this major surgery, and we saw this patient. I was down at Northwestern. This patient was in the Gold Coast room for the elite people.
Very nice.
Looking over the, what they call it, the playpen. And,
yeah.
And she's had the surgery on her right side, and she's brushing her hair. And I look at this woman, and she goes, "Oh, I'm pretty sore. Yeah, I'm pretty sore." And I go, "What's your pain score?" "Well, it's like a 4. It can be a 4 sometimes." And I wanted to tell her, last year you'd be in the ICU on a ventilator. I didn't say that, of course, but I was shocked that we were infusing 3 milliliters of fluid, a mixture of local anesthetic and opioid.
It's nothing.
But because it was in the right place, it was a highly technical thing to get a thoracic epidural in just where you want it. I was like, wow, we can do amazing things with minimally invasive procedures. And so that was one thing. And so I became very interested in pain management. My first job in Michigan, part was anesthesiology, but also to help them start a pain management program. And while I was there, I became friends with a nurse, a female nurse who was like a chief nurse in the ICU, who just full of leadership qualities, high quality person. She hurt her back, which is not uncommon for nurses, as you know, because all the manual labor they end up doing. And she went to see the leading neurosurgeons in southwestern Michigan. Her MRI didn't show any significant changes, which MRIs don't, which we'll discuss a lot about later. Yeah. And the neurosurgeons basically told her it was in her head. And I was like, that was one of those emperor has no clothes moments. Come on. This woman has pain. She's telling you of pain. There's something going on just because you don't know what it is looking at an MRI. And I just knew there was something wrong with the way we were treating the patients were being treated who developed back pain. In this case, it was back pain. And anyhow, that was a long time ago. We're talking about the early 90s. And there was not even a board certification for what we do then. And so the field, I've been there, part of the development of this field, and it's been an amazing journey. And the things we're doing now, compared to the things we could do before, I can't even describe to you what a change it's been. And I will say you're exceptionally well trained. Dr. Powers did his fellowship in Utah, and
University of Utah Health, Salt Lake City.
I'm just so happy that you were in that fellowship. The more I hear about it, the things you were exposed to, the advanced procedures you're exposed to, the procedures to help cancer pain that you're exposed to, we're just really excited to have you here.
Yeah. There's a lot of options nowadays too. You talk about epidural injections that were becoming very popular, and now it's branched out into so many other options now. It's like this gap between conservative management and surgery. It just keeps getting filled with more and more
It's
things.
True.
The more
it's
options, the better in a lot of ways.
I can't wait to discuss all those.
Yeah.
We will. I will say this, just kind of as an introduction to the next segment. We're going to talk about where pain comes from most commonly. Pain comes from a lot of different things, but there are some very common sources of pain, which we'll discuss more of in the next segment. And then we'll talk about more unusual causes of pain. We'll talk about medication management, which We have a lot of patients where the sources of pain can't be treated or can't be treated effectively. And we do provide symptom management with medications. That's a whole very big, important part of our field. But the exciting stuff is then going to be talking to patients about the minimally invasive procedures that are now available. They're hard to get approved sometimes, but the minimally invasive procedures that are now available to help people that we couldn't help before.
Yeah, and I think the biggest thing is that there's new stuff coming out almost every single year. So, even with patients that maybe 5 years ago we said there's nothing I can really offer you right now, there may be something new that has come out. And I know you've been a big part of the field as far as, kind of what do I want to say? Developing or implementing a lot of these new advanced procedures and being able to offer it to people.
Oh, you're right. I mean, this is early in your career, but the last 5 years, the last 7 years, it's pretty cool. Some of the things that I'm thinking specifically of the Minuteman procedure, the posterior arthrodesis procedure for spinal stenosis, and the Intraset procedure.
Basivertebral nerve ablation.
Which is, the basivertebral nerve ablation it's actually for disc pain, inflammation, disc and vertebral end plate inflammation, but we'll talk a lot about that.
Yeah.
But, the advances in the spinal cord stimulation that have occurred over the last 5 to 10 years, in the hardware and the software.
Yeah.
But you know what, Dr. Powers, I still get joy doing simple facet joint injections and nerve blocks to help people's pain.
Incredibly
you don't need
helpful.
these advanced procedures.
No.
We like them because we're helping people we could never help before.
Yeah.
But I still get a big kick out of helping people who've just been recently injured, where we take their pain away with a simple joint injection.
Oh, yeah.
Or an epidural for radicular pain.
Yeah, we're talking 90% or more of people will benefit from very non-invasive types of procedures that are, like facet joint injections,
exactly.
like epidurals. Yeah, the vast majority of people will get benefit from those. So,
well, I think you can sense our excitement about what we do. I've become more excited over the years, which is kind of fun since I'm getting older. This guy is starting out his practice excited, which is really neat. I mean, I transitioned from doing anesthesia and pain management to doing pain management full time, but we didn't have all these options that we have now. Plus, in those days, there was a lot of pressure to prescribe opioids, which we understood the risk, but patients would come in and say, "Hey, doc, I saw this advertisement, and everybody's talking about how well they're doing on opioids." And there was people that felt they had the right to them. And in the discussion with patients now, it's so different. People understand that opioids are as big a risk as having back surgery, and it can lead to a lifelong problems, and they have to be chosen and used very carefully and monitored very carefully. Again, getting back to this idea that if you can treat the source of the pain minimally invasively, one of the things that we do, that is the number one thing you want to do. Opioids, risky, short-term and long-term. Again, we'll discuss a whole segment about that. Surgery, risky, short-term and long-term. Magnitudes more than our procedures, and we'll talk more about that.
Yeah, if we're really targeting, and we'll talk more about it. But if we're really targeting inflammation, we can do a procedure that targets the inflammation, the source of why you're having pain. That's going to be better than any sort of Band-Aid that you could have, and of course saves you some of the side effects you can have with medications. So yeah, we always encourage people, let's treat the source here. Let's go after it. Of course we do also have options for medication management as well for when these things don't necessarily help or don't help enough. Most important thing for people is to maintain function. That's really I see that as the goal of pain medicine. If I could get you to live a fairly normal life, that's really the goal.
No, that's definitely improving the quality of life as much as we can, as safely as we can. And patient safety, that'll be a whole nother talk. Patient safety with the procedures, patient safety with the medications. That's probably enough for starters, don't you think?
Yeah, I think it is. We're going to talk about a lot in the upcoming episodes. We'll try to break it up into pretty digestible segments, and we'll be looking for any sort of feedback. If you have topics that you want us to talk about that we haven't talked about yet, we're looking for that. So we're going to appreciate all the comments.
In fact, if right now, I'll tell you, if you want to just go to painchicago.com, that's our website, you can send a message or a question through the website. There's an option for that, and I'll make sure that's working perfectly. I think our lead MA gets those, maybe our Janina as well. We have a great staff here. I want to say that too. Dr. Powers has been a wonderful addition, but it's taken me 20 years, but over 20 years. But we have a wonderful staff here, and if you have any questions you need answered, please just go to the website and check it out and send us a message. But we're going to do more of these, and we're looking forward to it.
So we'll see everyone in the next segment. Thanks for tuning in.